Hello, everyone. Today, I am talking to Dr. Salya Namazi. Dr. Namazi is a clinical psychologist who specializes in the testing and diagnosis of people who we could term as neurodivergent, autism, ADHD. These are terms that you've seen on your news feeds, that you've read about, maybe you've discussed with loved ones. Maybe you or a loved one is some flavor of neurodivergent. Maybe they have autism or ADHD. We talked about how to go about diagnosing these conditions, how to work with them therapeutically. I even share a little bit about my journey as someone who has ADHD and some of the things that work for me. I learned a lot from this episode with her, and I know that you will too. Before we get started, I would really appreciate it if you would like or subscribe, however you're listening or watching this podcast. I'd really appreciate it. Tell me, what is, if I wasn't a clinician, if I didn't know anything, how would you explain neurodiversity, just as a broad concept?
Yeah, so that is a really good question, and I am very excited to be here to talk to you about this too, Joe. So neurodiversity is a term that I believe was coined in the 90s to refer to people who are developing maybe differently than others. It's an umbrella term for populations. So when we use the term neurodiversity, we're talking about groups. When we use the word neurodivergent, we're talking about individuals. I know that can get a little bit confusing for people.
Yeah. It seems if I was someone that was on social media or Reddit or the internet and I was encountering this term, it seems to be closely tied to autism, the autism spectrum, and ADHD. And I occasionally see people actually will say like capital AUDHD. So they kind of combine those two kind of more traditional symptom clusters, I guess you could call it. Why does that seem to be so prominent, given that your definition for it feels so broad?
So neurodiversity can mean different things for different people. We do have some autistics who prefer to use the term neurodivergent instead of autism. There are people who've been diagnosed with both conditions like ADHD and autism who prefer to use the term neurodivergent. So they're really, in my view, it really depends on what label feels most comfortable for you. And it is broad, and I think it's intentionally broad because there are other conditions that could be considered to fall under that umbrella, like language disorders, developmental coordination disorders, learning disorders, disabilities, that kind of thing. So neurodiversity, neurodivergent, I think intentionally is broad for those reasons. I think you make a very good point that in today's world, we are seeing more autistics use the term neurodiverse or neurodivergent, I think more than others.
Okay. I also, it's been my impression. So I have ADHD and I treat a lot of ADHD in my practice, and I feel very feels very much within my wheelhouse, if you will. I have some modest experience with people on the autism spectrum. I wouldn't identify as an expert or like that's one of my core competencies. It seems to me that people may, and you tell me if you see this like clinically as well, that people identify as neurodivergent even if they have a maybe just kind of one or two symptoms, quote unquote, in common with that traditional symptom cluster that we would call like the autism spectrum. But I also see that a lot of people will actually identify other things that aren't in that kind of traditional list in the DSM or ICD and kind of refer to their nervous system in that way. Could you talk a little bit about how you approach, the more kind of like traditional diagnostic criteria versus the more kind of colloquial usage, or maybe some of the more cutting edge, quote unquote, symptoms or aspects of someone with this type of nervous system?
So when you say with someone with this type of nervous system, are you talking more specifically about autism?
Let's do that just for the example, sure.
Yeah, so there's a lot that I could say about this topic. So, traditionally, the diagnostic criteria was developed based on research with boys because we used to think that autism affected boys way more than it affects girls. And the way that symptoms present in boys is very different than the way it would present in a female. It's much more obvious. They tend to, not always, of course, there's always exceptions. And in fact, we're learning that there's more exceptions now. But traditionally, we thought that autistic boys were pretty obvious cases. It was pretty obvious to diagnose. I mean, we would see those pretty classic repetitive, self-stimming behaviors like hand flapping, insistence on sameness, and different social communication differences. And just in the past, maybe 10 to 15 years, we're actually learning that AFABs, assigned females at birth, there are a lot of autistic females out there. They present far differently than boys. They tend to need more genetics, actually, to turn on the condition. And they tend to be really good maskers. They tend to blend in the playground, for example. There was some research on that. They tend to be more socially motivated. So we used to think that autistic people may not want social interaction, but really we're learning that a lot of autistic people are very social people. They don't relate to others in the way that a non-autistic person might. So we are learning so much more about that. And we're also learning that for females, it's so much about the experience with the social skill versus the actual social skill that you can observe. So a female might be giving you good eye contact, but what is it taking for that female to give you that kind of eye contact? Are they having to remind themselves to look at you in the eye? Are they having to think about these things which are very natural for non-autistic people? The current DSM, there are specific symptoms that you have to meet to be diagnosed with autism. But we also know that there's some variability with this because a lot of females, again, and actually males too, and I'm saying gender because we have gender diverse people as well. So there's a lot that we could talk about today, Joe. With regarding the diagnosis, of course, this isn't specific to autism. As you know, as a therapist, we can have symptoms of any condition, one symptom out of here, one symptom out of there. It wouldn't necessarily mean we are autistic or we have ADHD or we have bipolar disorder, those kinds of things. You do have to meet the criteria. But again, there is some nuance in how you do this because with autism, for example, there are symptoms that you may exhibit that you grow out of. And according to the DSM, that still counts.
You mentioned masking, and you talk about how if there's a lot of intention and effort to be a certain way, that is one way that, if I'm understanding you correctly, that's one way that autism might go undiagnosed or kind of glossed over, or someone might not even be self-aware that they actually have these tendencies or patterns. Do you also see masking with people who have ADHD, or is it primarily something that you see in autism?
Sure. So I think we see masking across the board. I mean, I'm sure you mask sometimes, and I'm sure I mask sometimes. I think a lot of people mask. I mean, there are days I'm sure we don't want to go to work and we have to kind of put on a face and bear through it. For an autistic person, the difference there, in my experience, is that person is masking a lot, especially when they're in a social environment. So a lot of times our kiddos will be at school, and they'll be, behaved and they're doing great at school. According to the teachers, there are no issues. And then they might come home and they kind of just lose it. And they might decompensate in the home setting. And it's probably because they've been holding it in during the day, or they're, having to expend so much energy just to make it through the school day. And there's so much happening socially that they have to manage. And then at home, that's a hopefully a comfortable environment, and they're able to just relax, and they kind of they might, exhibit signs of like maybe some anxiety comes out, or mood regulation issues might come out then.
One of the ways I kind of explain mental health to the people I work with very broadly is I say, mental health, taking care of yourself, taking care of your nervous system is learning like how does your nervous system work? And this is true of anyone, regardless if they're, quote unquote neurotypical or neurodivergent or whatever it is. Learn how you work, learn how you respond to stress, and learn how to take care of yourself. Learn how to, learn how to recover when things are very, very stressful. Learn how much stress you can tolerate. safely, learn, when to kind of be in your nervous system and give it what it wants, and learn when to engage in kind of like the more adaptive avoidance strategies that we all engage in. And I'm thinking about all of this, and I'm thinking about, working with someone on the spectrum, let's say. How do you, I guess, like philosophically, ethically manage all that? Because I think it's probably a little bit tricky, right? Because on one hand, you want to honor how someone's nervous system operates and works, but then on the other hand, if honoring that causes problems at work or school, then there kind of is this kind of, it's like because I mean, you tell me how you go about it, but because it's kind of like, I feel like the impulse is to like say to not mask, but I also wouldn't tell a neurotypical person to, like, as your point, we all mask in some way. I would never tell someone to never mask, you know what I mean? And so it's kind of tricky.
So I think, your initial question about neurodiversity, I think this is where this, for me, comes into play when I'm talking to my clients. So I'd like to think of myself as an affirming provider. And for my autistics in particular, they've been wired in such a way where they are most comfortable, their amygdala is most comfortable, their limbic system is most comfortable when they're in a situation that is not highly stressful, that's not unpredictable, that there's maybe some people there, but the people, and it's not, novel unfamiliarity, and you kind of just know what to expect. I mean, this, for a lot of our autistics, not all autistics, but for a lot of our autistics, this is how they feel most comfortable. We don't live in a world like that. We live in a world that's extremely unpredictable. We live in a world that's socially driven. For instance, college. I tell my parents all the time, college is not so much about how smart you are. It's about how organized you are and how you can initiate, and it's very socially driven. That's why some of our autistics have trouble when they're transitioning to that next phase, and that's why we get accommodations, or we try to. So, and I'm kind of losing track. What was the initial question, Joe?
Thinking about how, like, so if you're working with someone clinically or helping someone, again, we're just going to focus on the example of someone on the autism spectrum, about how to kind of optimize their mental health, for lack of a better term.
Oh, the balance. Yeah.
Yeah, the balance, because
yeah. It's a really tricky thing, because the world we live in is so unpredictable. And oftentimes I'll use the analogy that socializing, as much as you might love socializing, it's like exercising for you. And you would never exercise 8 hours a day without breaks. Like, first of all, you shouldn't exercise 8 hours a day, period, because you would probably die of exhaustion. But imagine doing that. And that's what some of our autistics do. I mean, that's what a lot of our autistics have to do. And that's why we see higher rates of anxiety. We see autistic burnout. We see a lot of depression. I mean, that's why. So learning how to balance, how much do I have to mask? How much do I have to be in these situations versus giving myself breaks? And that's where diagnoses can actually be really useful, because a lot of my autistics feel so validated after they learn about this, that it's not that something's wrong with you, it's that you're wired differently. And for an autistic person, it's not really conducive to the way the planet operates. At the same time, there are a lot of things an autistic person can do, such as meditation, psychotherapy, I think intermingling with other people who share, your traits. I mean, there are a lot of things an autistic person can do to survive and to actually make a difference and to feel really good. But it takes work to get there. It can take work.
You brought up accommodations earlier. One of the questions I've had about all the awareness in this area, like societally speaking, is, people will say, well, exactly what you just said, my brain is just wired differently. Like, this isn't, this isn't a disability. It's not a mental health diagnosis. It's like, I'm just a different type. I'm like the kind of broad taxonomy of humans and nervous systems. And I'm not even against that interpretation. It makes sense to me on a certain level, but I'm also aware that, for some people, like disability accommodations are actually essential.
Yes.
And then there's people who get overwhelmed if they have a very social job and they're socializing all day. And then there's people who are nonverbal, and we kind of put them on this spectrum. And so how do you understand that from everything from kind of like disability to kind of just like neurodiversity. Is that even fair to kind of juxtapose them like that?
Well, I think you're bringing up a very good point, because it is interesting that as a field that we do put everyone kind of in this one category when there is such variability. And, oftentimes I will be asked, like, is my child mildly autistic? Or they've said, like, what can you tell me, like, how impacted they are? And I actually stopped using those terms. I used to say mild. I used to say, I used to do that. I don't anymore, because I found that saying that someone was mildly autistic just because I'm not seeing significant problems or significant distress doesn't mean they're not experiencing it. And it could be quite invalidating for an autistic person to be told, oh, like, you're just mildly autistic, when this person's like, well, wait a minute, like, I have no friends, or I have to work up all this energy to just go talk to like, for an autistic person, it can actually feel quite invalidating. But it is an interesting concept, because we used to have Asperger's and we don't anymore. And they replaced it with this other diagnosis that I think is rarely used, actually. And I think the point was to replace the diagnosis with social communication disorder that, I don't think is used that often, turns out. So, I mean, it's interesting. I do think a lot of my autistics I see do need some accommodations. And really the way that I explain it to them is, we're in a planet that is not that's an unpredictable world. When you go to college, you're expected to take 5 classes or 4 classes. You're expected to initiate with your professor if you're struggling. You're expected to maybe have a roommate, and remember to shower and eat 3 meals a day, and all of these things we expect all of our kids to just be able to do. For an autistic person, and for someone with ADHD, actually, that can be really hard to remember to do all those things. And that's where accommodations can be helpful. And it's not so much thinking about it from a disability standpoint, but it's thinking about it from a standpoint of, understanding what I need to be able to function in this world. And I will also say, sometimes I'm a very short person. I'm 5'2", right? If I need to grab something that's high up, I don't just, grab and say, oh no, I can't do it. Oh, well, I grab a stool. These are stools.
One way what you're saying makes a lot of sense to me is that someone might have a proclivity to experience depressive symptoms under extreme stress, just as an example. And even though the current kind of language of speaking about depression is like, is it mild or moderate or severe depression in its presentation, but it is interesting to consider that for so many people, even if it is mild in the sense that we mean it, if they are put under sufficiently more stress, or if they go off their medication, or if they stop going to therapy, or if whatever happens, like, it can actually become quite severe quite quickly. I mean, therapists see this all the time, when we talk about different, how, if we think about how most, if not, I would say almost all mental disorders in the DSM, one way to understand them is it's your nervous system's response to stress. So some people get anxious, some people get depressed, some people, their personality disorder symptoms become quite rigid. Other people, maybe they struggle with a disordered eating, or like whatever it is. And so it's just occurring to me in this moment, what's kind of cool is it doesn't actually, the way you think about working with this population doesn't actually feel that different from what I just described.
Yeah.
In a certain kind of way.
Yeah, I think that's spot on.
Yeah. How do you understand the role for kind of individual responsibility and agency? You've brought up a couple of times this idea of like understanding that the world is not designed for me, like as someone who is kind of neurodivergent, and I bring it up because it's something I see a lot in comment sections. I do a lot of comment analysis, and I see that there's this when we think about individual agency or responsibility, it can or when I've talked about it, at least, some people can interpret it almost as kind of shamey, and that's never what I'm trying to do, because I would argue that there's also well, you gotta take care of yourself. You gotta participate in society and kind of do all these things. I think it's, how do you understand that, given that understanding how your nervous system works as juxtaposed to how the world is designed for a different kind of nervous system. Like it seems it's just another kind of complex inquiry that I've had about this group and for myself.
Yeah, I mean, I wonder if that feels for the person because at the same time, I hate saying that the world's not designed for a type of person, right? That doesn't feel comfortable saying that. And it almost sounds pathologizing at the same time. So it's a very difficult balance. I mean, what I commonly say, so just like you described earlier, some of my neurodivergent folks will in the height of stress, they'll freeze and they'll avoid the stressor. And some will get very dysregulated and maybe act in ways that seem pretty disproportionate to the situation. So I think it really depends on the individual's presentation and their response. We also know that there's a lot of our autistics, and actually there's a high rate of sensory sensitivities in ADHD, as you probably know. So, individuals with these profiles can get quite sensory overwhelmed and sensory overloaded. So if that's the case, again, explaining to them that they really need to be taking care of themselves by using different accommodations, such as using noise canceling headphones, being in darker rooms. For someone who has that more avoidant style, I'm often recommending psychotherapy, where they can learn some self-advocacy skills, some initiation skills. Sometimes our autistics have difficulty with interoceptive awareness, which refers to your ability to understand your body signals. So when you're feeling hungry, when you're feeling thirsty, when you're feeling your heart is starting to race and maybe I'm getting anxious. And we actually have some really cool treatments that target that as well. So it really depends on how a person is presenting and what their goals are.
Yeah, absolutely. I really like that. The interoceptive awareness piece, I know that in my just clinical experience, I will occasionally get someone who comes in and they're let's say they're just having some just kind of general cognitive trouble, and one of the first questions I have learned to ask is like, what's the last thing you had to eat? Like, how much have you had to drink today? It's kind of some of the more kind of like basic life skill stuff. And sometimes I get this answer that's something like, well, I had a taco the other day. And I
Wow.
clarify, I go, have you had anything else? And then it's kind of like, okay, before I diagnose you with,
Right.
whatever I might diagnose you with, it's like I need you to and it's not an eating disorder, to be clear. It's like, and so I guess I'm wondering if that is a signal to maybe actually like look through like kind of a more kind of like neurodiverse lens and get curious
Yeah, I mean,
in your opinion.
yeah, I think I would ask more questions. I would ask more about, do you often feel hungry, or do you get to the point where you're hangry? Do you feel thirsty? Do you know when I mean, basic questions like, do you know when you need to urinate? You might be surprised what people say. How do you experience pain? Some of my autistics don't feel pain like other people. And actually, that's a sign in childhood. If a kiddo is running really fast and they fall and they kind of just get up and they keep going, and you're like, whoa, you're not crying, you're not in pain. That's an
Interesting.
unusual response to pain. I'm wondering, as someone who specializes in ADHD, do you hear these kinds of things from your clients? Because I hear more of that in my autistics.
Yeah, I think I hear, well, I mean, one of the best things I found for ADHD is I get very like behavioral, at least at the beginning with them. And it's kind of like, no, I don't care if you're not hungry.
Hmm.
Like,
Hmm.
like eat on time. Like, like I
Right.
don't care if you're not
Routines. Yep.
thirsty because and what I'm really trying to do, well, there's the routine part of it, but then it's also kind of, I'm trying to like almost like resensitize them to their different cues. So for example, I've noticed, and this is really anecdotal, this isn't derived from any research. I've noticed that, for some people when they, get thirsty, their mouth feels dry and they get thirsty. But then I've noticed that with my patients with ADHD, and I've also experienced this in myself, it's like, that's actually not the first thing I notice. Like the first thing I notice is actually, it's like, I can't, like, I notice I'm reaching for my phone more. I like feel more distractible. And it's like,
Uh-huh.
it's almost like the kind of, to me, I've experienced it as some of the more kind of typical ADHD symptoms are actually like the first to kind of arise when my body, like my biological system, is like thirsty or hungry or whatever it might be. Something I've also done, and I don't do this with patients as much because it's just kind of a tricky ethical area. I typically refer them out, but supplements and nutrition have been a huge part of my self-care. And I've just noticed that if I'm, taking the vitamins that I know like really like work for me and like eating really clean, and by clean, I mean, more whole foods, basically, like meat, vegetables, et cetera. I've noticed that my Adderall dosage actually has been cut drastically down. I used to be comfortable on like 10 to 15 milligrams of IR was always what agreed with me. And now I can take 5 and be fine. Now, the exception might be if I've had a weekend where I'm drinking like a lot of alcohol. I noticed my ADHD that Sunday is out of control. You know what I mean?
Sure.
And then if because that's just life, right? Like I can't just eat super clean and drink like a ton of water like all the time. Like life gets in the way, like work gets busy, or having ADHD, like I will occasionally forget, or whatever it is. And so sometimes I will kind of, by my discretion, I work with my prescriber and I just increase that dose, and it seems to work really well for me. But anyways, that's a very long way of me saying that I've noticed that some of like the routine, sleep has been huge. I used to have a lot of issues sleeping, and again, just through just kind of general sleep hygiene, and also just a couple of I've tried medication for sleep. It didn't agree with me. So some of the more kind of naturopathic remedies do seem to work really well. And I wake up and there are some days I don't actually feel like I need to take my Adderall, but then some days I'm kind of like, oh, this is going to be a long one at work. And like, I need that support, kind of to your point. I need a stool.
That's incredible.
And that's one of the ways. Yeah.
So 5 milligrams immediate release seems to be what you need. I mean, that's.
Well, I also think my system seems to be very sensitive. I think that, I think 5 milligrams to me probably feels like 10 or 20 to
right.
other
I was actually going to say that. Yeah.
Yeah. Speaking of just kind of different ways to kind of like take care of yourself and like think about this stuff, the sensory processing piece. I know that in my therapy journey, I briefly worked with a specialist, and one of the things she just constantly like reflected to me was she would say, you are physically like sensitive, like in terms of kind of like the sensory processing. I don't identify with having like a sensory processing issue. I don't think I'm quite sensitive enough. But she goes, but you are like kind of normatively sensitive. But then she would say, but intellectually you require a ton of stimulation. And I've noticed this
That's pretty classic ADHD.
Yeah, in friendship, in work. I think it's one of the reasons why I like being a clinician, and I like getting in front of the camera for any of the media work I do, because it is often intense,
Yeah.
But also even in stuff like around just like kind of other pleasures of life, like the music I like the different sexual styles of things that I enjoy, all seem to kind of really intensely stimulate me like intellectually, which is just which, as you said, it's classic.
Oh yeah. I mean, I hear from a lot of my ADHD folks that boredom is like really difficult. I mean, boredom must be really hard to tolerate.
Yeah.
Yeah, I mean that's the dopaminergic system. I mean, you need that dopamine, and you're not getting it if you're bored.
Yeah.
And when you're stimulated, you're really getting that, and it feels really good.
Yeah.
So that makes total sense.
Totally. I know that one of the things that has been important for me is a mindfulness practice, and I know that I actually recall the first time I started doing it, because I was in therapy. I was still in grad school, I think. And I was like, well, I can't ask my future, patients to meditate or practice mindfulness if I haven't done it before. And I remember being like, okay, so just so I'm not tempted to grab my phone or anything, I'm going to get in the bath. And I drew myself a bath, and it was like, no music, and it was kind of dimly lit. I was like, I'm just going to be here with myself. And I remember when I first tried it, it was excruciating. I mean, I don't think I lasted like a couple of minutes, but I did gain tolerance over time. Like even with my quote unquote neurodivergent self, there was still some plasticity there, you know?
And I think that that's
Yeah.
true. I mean, I think you can,
Yeah.
I mean, you would know better than me being an interventionist because I just do
Yeah.
evaluations, so I don't do intervention.
Okay.
And that's why
Yeah.
I refer to you guys because you guys are
Yeah.
the amazing interventionists out there. But I would think that you could, at some level, train yourself over time and
Yeah.
scaffold yourself to get there. I
Yeah.
also find that different types of meditation are better for people with ADHD. So transcendental meditation in particular, I think can be good because it allows you to think about other things. You don't have to be focused
Yeah.
just on one thought.
Yeah. For me, it's been the best modality has actually been like a sound bath or a sound healing.
Okay.
And there's, I mean, I don't know if there's any like research or, you know, whatever done on like the actual frequencies, et cetera, that feels, that starts to get a little too new agey even for me. But I think there's something for me, you know, I'm such a verbal person, you know, like I literally talk and listen for a living. It's all I do. And so for me, it's always made sense that it's like, oh, when like I can just focus on that frequency, that's when I really do kind of achieve that meditative state after, even if my mind wanders off and kind of coming back,
It's
it's always
amazing
seemed to
you've
work for me.
been able to learn that for yourself.
How do you understand the connection? It's my understanding that there is a high, what would I call it, like overlap or kind of a comorbidity between autism and ADHD. And it's been I haven't done a ton of reading on this, so I'm hoping you can help me learn something new here. That it looks like when they're studying the brain structures, that there's actually like there is some overlap, and that's why people are often diagnosed with both, but they're not always. I remember asking, you know, the specialist I worked with, I was like, do you think I'm on the spectrum a little bit? And she laughed at my face. She was like, no. She was like, that's not your problem. Not that it's a problem, but you know what I mean. I was like
sure.
concerned with different things I was dealing with, and she was like, that is not what's happening with you. She was pretty certain. But what is the overlap? Can you explain that a little bit?
Yeah, there's a huge overlap, Joe. And you know, with ADHD, so it's attention deficit hyperactivity disorder, so we would expect to see attention difficulties. So someone with attention difficulties can also look different though. So you might be able to focus for short periods, but you have trouble in prolonged situations. So you might be able to get yourself started and you get yourself going for a couple of minutes, and then you might get bored and kind of go off to something else. And really struggle in those short and in those prolonged periods. And someone else with ADHD might have the total opposite profile. And this is why I love my job so much, because everybody's different. And it's so amazing putting these pieces together and helping people understand themselves. I just love it. In someone with ADHD, we would expect to see some executive functioning difficulties as well, because it's all the same part of the brain. It's the prefrontal cortex. The part of the brain that's responsible for executive functioning is actually the last part of the brain to develop. So we don't see full maturation in this part of the brain until you're like 26, 27. And someone with ADHD, we think the prefrontal cortex is probably 3 to 5 years behind their peers. So, you know, they're seeing a delay in those areas. A lot of times okay, so this is anecdotal, so this is not research-based. In my experience, we do see a surge of development in your 20s. So you may see a totally different person, and I don't know if you've experienced this, from age 22 to 26, like even in that short of period, because that part of the brain has pretty much matured. Now, with autism, we would expect to see some executive functioning. Very likely, we would see some executive functioning vulnerabilities. Usually in autism, we would see difficulties with flexibility. So difficulties with change, novelty, needing sameness. And if those difficulties give rise to social differences, and they meet, you know, those certain criteria that we have to abide by, then that's what we would maybe consider calling it autism. Someone with ADHD wouldn't necessarily show that pattern. But what gets tricky is that you can have ADHD and be inflexible, but not be autistic.
Interesting. Can you say 2 more things about that?
Yeah. So, and rigidity, so I'm 99.9% sure this is the case, but I'm pretty certain that rigidity, autism is the only condition in the DSM that rigidity is an actual symptom. So it is, I'm pretty sure.
I think that it might be an OCD-PD or OCPD.
So in that type of rigidity, you're right, is a bit
Yeah.
different than the type of rigidity
Yeah.
I'm talking about. But I think
Okay.
that's
Can you
that.
differentiate them?
Yeah. So in autism with the rigidity, you're kind of acting the way that you're acting because that's just how it feels comfortable. In OCD,
Mm.
it's an anxiety-driven response. So you're doing compulsive behaviors to kind of combat these intrusive thoughts because there's an anxiety etiology. In autism, it's more of that autistic etiology. Does that make sense?
Mm-hmm.
So in autism, the core being the rigidity piece, we're trying to detect or understand if that rigidity is developmentally driven. We would see signs of that when kiddos are young. So there's different ways that we look for this. So some kids, the way they play, oftentimes an autistic person might play differently. So they might not show as much imaginary play. They might, enjoy categorizing and sorting toys. They might line things up in different ways. And someone with just ADHD, you wouldn't necessarily see that. But in ADHD, you might see someone who is a perfectionistic, maybe a bit type A, which could be considered rigidity, which we also see in autism. But for someone with
Right.
ADHD, it's not really the core feature. In autism, it is.
Yeah.
Oftentimes, it is.
Right. So it's kind of like the etiology, or for those listening and watching, that's kind of like the origin of the quote unquote illness or like symptom or
The
whatever it
cause, yeah,
is.
yeah.
The cause. So it's all about the etiology. Because I know that for me, as I've gotten older and I learned my nervous system, I've noticed a little bit more rigidity, but the rigidity is from the routine that I know
That you
keeps
need.
me
Right.
that I need. And so
Exactly.
that's from a completely different etiology compared to someone with like, OCPD or on the autism spectrum, or someone who's like inflexible in ADHD, because that's maybe like more connected to like a personality trait or something like that.
And you know more about OCPD than I do, but my
Yeah.
understanding with OCPD, there's definitely rigidity there, maybe rule following behaviors and then that kind of stuff. But you wouldn't necessarily expect the rigidity to affect the social part of life.
Yes, I would say that it's interesting because I don't think I talked. So for those who don't know, we're talking about obsessive compulsive personality disorder, and it's basically like you take the flavor of OCD and you kind of put it in a personality. And so
Mhm.
people like this are rigid, like we said. They're often very frugal, stingy. They can have difficulties with affect as well. They're highly perfectionistic. So these are like
Mhm.
your real pathological perfectionists. And I think I've seen extreme or more kind of like people that are impacted more by this diagnosis. I have seen it kind of cause social problems, but to your point, in the more mild to moderate manifestations of it, they're often actually like really well liked and popular and successful at
Mhm.
work. And
Mhm.
so it's
Mhm.
kind of interesting to kind of consider the how their rigidity shows up. I don't know if this might be too oversimplified, but I've observed like their rigidity, it's almost more like internally imposed. It's
Mhm.
like, well, I have to have a body that looks like this, and I have to go to the gym like this, and I have to like, because I have to be, whatever it is. And there's it's often, in my experience, it's often very like shame based,
Mhm.
versus the kind of rigidity that you're talking about with someone on the autism spectrum. It has this different like flavor, like it's the different etiology. Like it's like, well, if it's not rigid, I will become dysregulated, or like if it's not predictable or whatever it might be.
Right. And it's developmentally driven. It's the wiring of the
Yeah.
person. So it's the way that they've been wired. And as a little one, again, there are signs of this. And that's why we try to always get collateral reports. And we try to talk to parents when we're able. I mean, a lot, when I see adults, it's often not the case that I'm able to do that. So I have to try to get developmental history in other ways. I've called
Mm.
aunts and grandmas and uncles and, preschool teachers. I mean, you name it. I've called all sorts of people to try to get
Mhm.
some more information. But it gets really tricky. And also, that you can have social difficulty and not be autistic. You can have social difficulty
Mhm.
and be
Totally.
depressed or ADHD. Or, I mean, so social
Mhm.
difficulty is also not specific to autism.
How do you understand the role of neuroplasticity in the diagnostic process? Because it seems to me that, because I mean, I'm thinking about what I shared earlier about like my ability to be mindful
Hmm.
and be present, was very difficult, arguably more difficult for me at first than maybe someone, without ADHD, let's say, just for the sake of argument. But I also know that in some ways I kind of like muscled my way through it, for lack of a better term. And I've seen those benefits. And so with all the research with neuroplasticity, given that this is like a neurodevelopmental disorder, like where do you draw that line? Because somebody could become totally addicted to TikTok and start experiencing very real, kind of ADHD symptoms, right? Arguably, and kind of like searching for dopamine all over the place. But I'm not sure it would be, fair to say that they have like a neurodevelopmental disorder if for the last 3 years they've like trained themselves in a way.
Yes.
So how do you understand that as someone that does the testing?
Yeah. So it's hard. It's really hard to understand and uncover when the symptoms started, because we also know, and you alluded to this earlier in your own experience, that lack of sleep actually can produce symptoms that are pretty much identical to ADHD. But it's not because you have ADHD, it's because you're not sleeping. We also know that...
Or your sleep is disordered.
Exactly. We also know that psychiatric conditions like high anxiety and depression can mimic ADHD symptoms. We know that lack of exercise. I mean, there's so many environmental factors, and the TikTok example you provided that can pretty much produce symptoms or make it look like you have ADHD and you really don't. And on testing, there are different patterns we're looking for, but I'm more so asking questions about the onset. Like, when did this stuff start? Did you notice anything earlier? And with boys, we might see some more hyperactive symptoms, like, oh, he couldn't sit still, or oh, he's so fidgety. And with girls, the thing about girls that makes it really tricky is that girls tend to be more inward. They tend to be the ones who are kind of daydreaming, but you don't really see it. You think that they're paying attention, you think that they're doing their stuff, but really they're zoning out, and you don't see it.
Yeah.
So you don't necessarily see inattention. So that's why oftentimes I'm asking teachers for input. And like I said, I call all sorts of people to get other reporters about the child or the adults, because, it's very important to tease all these things out. And sometimes I'm saying, I don't really know. You have all of these other things that haven't been treated, and we really need to treat these conditions. And we need to revisit this when that's treated. That does happen. And I'm a provider who isn't scared to say that I don't know, because I still think there's so much we need to learn about all of this, and we're still learning. And I'd rather not. I mean, if I were in that person's shoes, I don't want a doctor telling me I had something if they weren't convinced I did. So I try to treat people that same way.
Yeah, fair enough. At the beginning of our talk today, you talked about how it can be such a relief to be diagnosed with like autism or ADHD. And I think that's true, not just of, in terms of kind of this conversation, but I think that's true of any properly done diagnosis.
Yes,
people
agreed.
often experience it as a huge relief. And I mean, it's something I've been talking about with my platform, and I write about sometimes. It's like, a diagnosis is not the worst thing that can happen to you in mental health. The worst thing that can happen to you is no one can name what's happening, and you just keep on getting sent up the chain, to different specialists or different psychiatrists, and they're just kind of throwing stuff at the wall. That is, in my experience, getting a patient where that's been part of their journey is much harder on people than even getting diagnosed with something, kind of scary and taboo, like a personality disorder, which, I treat a lot of, or whatever it might be. And so,
which I would love to also hear from you about that. I mean, to me, calling borderline personality disorder shouldn't feel taboo. It's like, there is a label to explain why you're so sensitive and why you're experiencing these things. And for me, that's how I roll when I'm talking about it.
Well, not only should it not be taboo, but it's actually, out of all the personality disorders you can be diagnosed with, it's a hopeful one.
Yeah.
I think they get a bad rap because, if someone isn't diagnosed and they have low insight and they're not self-aware, they their relationships are chaotic. That is actually one of the symptoms, a lot of instability. And so I think that's one of the reasons why there's some stigma and a bad rap there. But we know that with the right, kind of like attachment work and DBT and, with the right support, within a couple of years, they're going to be, if not symptom free, it's going to be much less
Right.
impacting their lives. I was talking to another researcher, Dr. Carleen McMillan, and I was absolutely fascinated to learn about how they've experimented actually with bringing people with narcissistic personality disorder into group therapy, and how they're finding that actually in a group setting, they're actually seeing real progress in terms of self-insight, which I think is so funny and ironic and paradoxical, but exciting. Because it's like I'm a narcissist, so special me, put them in a group and they see everyone else doing the exact same thing. It's able to help them see it.
I love that. And that is so interesting, Joe, because last week, I recommended that for that reason to a child. Because this child had really poor insight. And I said, I wonder about a group for you.
Yeah.
Literally.
Totally.
That's what I did. That's so interesting.
Well, I don't work with children, but I imagine that if I was and they were, there was like potential for kind of, neuro divergence or kind of something developmentally happening. Like I think a group makes sense because then you actually get, one of the more kind of unpredictable but beautiful things about a group is like you can't even like predict all the interactions between all the people, like you know what I mean? And so I think that's one of the reasons why they can be so powerful.
Agreed.
Speaking of children, how do you think about that? I think that a lot of people listening to this and a lot of people who follow me, one of their concerns about a lot of the information that's out there, like on TikTok or Instagram or whatever it might be, it isn't just that there's, misinformation. It's also that people kind of grab on to these labels as an identity, and then they're disincentivized from like growing. And so from someone who literally tests, I don't know if you test or work with children and adolescents, how do you think about that? Because sometimes brains, and maybe you can teach me a little bit more about this, my understanding is that they can develop asymmetrically. Like, it's like, yes, you're socially awkward now, but like you might not be in a few years. Like, you know what I mean? Like there's a lot of moving parts.
Right. And we also know that if we can intervene, at a certain age and we get in when the kiddo is young enough that they might, fall off the spectrum if that's even,
through
there's some
therapy
research.
or
there's some research on that. Just through intervention. And again, that's tricky because it's also pathologizing autism, which I try to not do. I mean, there's autism in my family. So I think having that lens, like I see it every day, it helps me understand my parents, and also I see a lot of adults too who've gone through life and undiagnosed, and they really want to know. And I think I'm often asked, and it's usually by parents, if my daughter finds this out, is she going to use this as a crutch? Is this going to be an excuse to not do things? And I think the way that you have to explain it to somebody makes all the difference in the world. So we can take autism for an example. Like, yes, I think you're autistic, and these are the reasons I think you might be autistic. At the same time, I believe that autism is amazing and that we need autistic people on this planet, because autistic people tend to be the ones who are driving social justice movements. They tend to be the ones who are fiercely loyal. They tend to be the ones who don't lie, who are really good with animals and older people and younger people. And it's really trying to shape the delivery of the message in a sense where you're motivating the person to use it for the good instead of the opposite. And I think it depends on the type of provider you are. So if you operate from more of a pathology, which of course some of these things are, and sometimes we're saying like, oh, there's significant depression and there's things that you have to treat in a different way, but I think it so much depends on the delivery of the message and then the follow-up care. So because I don't do therapy, I'm often referring to trusted providers for different types of treatments. And I think the diagnosis is so important because someone, an autistic person might look like they're super anxious, but really they're struggling with the bright lights and the loud noise. So you wouldn't necessarily do exposure techniques with that person. You would teach them accommodations, like how to manage the sensory overwhelm. And that's where therapy can be really useful.
And to that point, that is the value of a different diagnostic label. Like if you are experiencing sensory processing difficulties, well, the reason why we want to label it differently is because then the treatment plan can help you.
Exactly.
Versus if you are anxious, then that is a completely different treatment plan. I
Correct.
sometimes use the example of, treating OCD is actually a little bit different than treating anxiety. And that's
Yes.
like why they're separate. It's
Yes,
not because
yes.
we're pontificating, you know what I mean, about
Right.
like different ways like the mind works. It's like, no, like there's actually a different protocol.
And I don't know how you feel about this, but I find like DBT, dialectical behavior therapy, can be effective for everybody. Like I feel like that's a therapy that a lot of people could benefit from.
I was trained. Well, for any practitioners listening, I know some people have very strong feelings that DBT has to be facilitated a very specific way
Yeah.
over like 50,
Offensively. Yep.
or
6
whatever
months, I
whatever.
think.
I was yeah, exactly. I wasn't trained that way. I was trained that it's something you can fold into treatment, and that it's when I bring people through a DBT course, it's always like between 12 and 16 weeks. And usually co-occurring with talk therapy. And I remember when I was learning to do that at my practicum site in grad school, I remember reading through the DBT book, and a lot of it I was like, oh, like that's a nice way to explain like a concept I understood, intuitively. And then other things I was like, wait, you can do that? Like it was kind of like there were a few surprises, and I don't know anyone that's gone through a DBT course that didn't learn at least one thing.
Yeah, agreed.
Or one
completely.
skill.
Yeah.
Yeah. As we get towards the end here, some people, a lot of people, I would say, particularly my comment sections, and these are people that I identify as part of what they call like the neurodivergent movement. And then there are people who are also very critical of it as a movement.
Yeah.
Can you explain a little bit, well, like, what do you mean by movement, first of all? And then like, to your understanding, like what are the arguments like for or against categorizing it that way?
So I think an extreme view on anything is problematic, and I think you're spot on, Joe, that there tends to be this divide, and you have some people who are very much on one side and some people who are very much on the other side, and I tend to take an approach where I don't want to change people, and I think that's where the movement I think is that's the manifestation of this movement. I am who I am, and you shouldn't try to change me. There's nothing wrong with me, and I tend to agree. At the same time, like I've been saying, this is an unpredictable social world, and there has to be some give and take here. And I think the planet needs to learn more about autism, and then I think that the autistic person is going to need some help in navigating the world. So I think there's this balance. In this kind of this push and pull, and this movement has gotten really popular. And again, I think autistic people deserve this. And we're about to finish Autism Acceptance Month, and this is my favorite month of the year. And I'm a person who just loves autism. At the same time, I think being that an autistic person is wired a little bit differently, and they are on a planet where it's largely non-autistic. I mean, autism, the new base rate is 1 out of 36. It's getting more and more diagnosed. It's more and more frequent now, but it's still 1 out of 36. So there has to be some, I think, give and take too. I hope that answers your question.
Yeah, it does. I've been very interested in this figure. I believe is her name Judy Singer. I think she may have coined the term, and it was very interesting for me to learn about how she how in some ways it was kind of more of like a social political term, and so while today's conversation was very clinically focused, it would be even fun to have you back another time, because I'm doing a different episode to kind of look at it more from like the political lens, because there's so much.
I wasn't sure if we were going there
different
today.
I mean, it was just such a different cut, and so I'm curious in learning more about it as someone who is. I think personally, I don't necessarily identify with a particular movement. I feel like I've, been really lucky with the support I've gotten around my ADHD, and my message is always about one of empowerment and really like truth, right? So like if the truth is that about 1 in 36 people are developmentally different, in a meaningful way. Like, what does that mean? Like, what does that mean, like, for society and like how we understand? One of the things I talk about when I think about, mental health stigma in general is I say, I want trauma to be and PTSDs to be as well understood as diabetes. That person needs the insulin shot. That person might need to regulate for a few minutes and kind of come back into their body because they were triggered. You know what I mean? And I think that we can make the same awareness possible for like really like, I think like any kind of symptom cluster. But to your point, I do see people take it a little bit far. I see, commenters basically being like, well, actually, like maybe like we're the majority and like the world like needs to change. And I go, well, maybe,
Well,
depending on what you mean.
I think it's both, right? I mean, I think
Yeah.
that there are parts of I think the world should be changing. And I think that we are trying, at least I hope we are. But I also think that there has to be some skills too. Again, depending on the person and their goals. I mean, that's really so much of what I drive home. And I was saying this to someone just yesterday. I mean, she asked me, what do I do? I'm like, well, let's talk about what you want to do. Let's talk about what kind of change you want to see. I mean, we have these treatments that are specific to someone on the autism spectrum. That doesn't mean that that treatment is for you. It doesn't mean you actually need that treatment.
Yeah, I know that someone I work with, something I say to her is I go, this problem that we're talking about right now, like, is it your tendency to be, to prefer being literal, or, like, is this an example of kind of the more black and white thinking? Like, can we actually break out of this and will that actually help you see this problem like more clearly? So I love ending on that message of
Yeah.
both and,
Yeah.
because I think it's arguably also quite stigmatizing to say that, someone with autism like couldn't engage in a cognitive distortion. You know what I mean? Just because like their thinking prefers a certain pattern, like,
Right.
and if
Right.
thinking about them in both terms helps them, then as a therapist, as a professional helper, well, that's what I'm interested in.
Yeah, that's a very good point, Joe.
Yeah. All right. Well, as we wrap up, are there any kind of words of wisdom or anything you want to leave with anyone listening and watching?
Oh gosh. Just that I'm so happy to be here and to talk about this. And I try to be neurodivergent affirming. I think it's a cultural awareness that I'm really trying to learn about. And I hope I was able to explain that today.
Yeah, no, I mean, I certainly learned a lot from you, and I'm sure people listening did too. For those of you who are still listening, this is a conversation I had with Dr. Salya Namazi, and she practices out of Maryland. And so you can look her up on the appropriate postings if you're seeking testing. She's not a therapist like me. She does psychological testing. And for those of you that have been enjoying these episodes, remember you can listen to Therapy versus the World early and ad-free, but only on Luminary.